Hello, everyone. I'm Dr. Carmen Pugliafito, and welcome to Retina Synthesis. Today, we're privileged to have with us Dr. Eric Schneider of Tennessee Retina, based in Nashville, Tennessee, to discuss some of the results from the PHOTON study of high-dose Aflibercept for the treatment of diabetic macular edema. Eric, welcome to Retina Synthesis.
Thanks, Carmen. Excited to be here. Thanks for having me on.
So, high-dose Aflibercept, the 8 milligram dose, is now approved. And the PHOTON study gave us a roadmap of how to use this drug. Can you tell us about the PHOTON study? Give us a high-level review of the study and its results before we talk about your particular sub-study.
Absolutely, Carmen. So yeah, the PHOTON study was obviously the pivotal phase 2/3 multi-center randomized trial that examined the use of the 8 milligram of aflibercept in patients with center-involving DME. In this study, patients were randomized 1:1:1 to aflibercept 2 milligrams Q8 weeks, aflibercept 8 milligrams Q12 weeks, and aflibercept 8 milligrams Q16 weeks. It's important to note that there was a difference in the initial loading doses. Patients in the 2Q8 arm received 5 initial monthly injections, while patients in the aflibercept 8 milligram arms received 3 initial monthly injections. The primary endpoint in the study was non-inferior BCVA gain at week 48 with a non-inferior margin of 4 letters. Another important thing, you look at the dosing schedule. Beginning at week 16, patients in the aflibercept 8 milligram arms were eligible to have their dosing interval shortened if they met the specific dosing regimen modification criteria, which included a greater than 10-letter loss in BCVA, as well as a greater than 50 micron increase in central retinal thickness. The interval could be shortened up to 8 weeks, or sorry, I should say down to 8 weeks during the trial, and there were multiple opportunities throughout the trial to shorten the interval. Beginning in year 2, patients could actually have their dosing interval extended if they had a less than 5-letter loss in BCVA, as well as a CRT of less than 300 microns. And for both the extension as well as the reduction in the dosing interval, that was relative to week 12. So there was some ability from a flexible dosing standpoint to see exactly how well a patient could do with the high dose of aflibercept. If we talk about results, the patient population, it was a pretty typical population with center involving DME. The baseline best corrected visual acuity in the 3 arms was around 20/63, and the CST was around 450 microns in each of the 3 arms. And about 45% of patients had prior treatment for diabetic macular edema with anti-VEGF therapy. I think the important outcome here, at least from the FDA standpoint, was the primary endpoint, which was, again, that mean gain in BCVA at week 48. And both aflibercept 8 milligram arms, both the 12 and 16-week dose arms, did meet that primary endpoint with non-inferior BCVA gain at week 48. If you actually talk about letters gained, the 2Q8 arm gained about 9 letters. 8.8 letters for the 8Q12 and 7.9 for the 8Q16. And there was a similar improvement that was carried out to week 96. If you look at kind of durability, two different ways to kind of look at durability in this trial. One is injection number, right? Obviously, a more durable drug will require less injections, and that was true with the aflibercept 8 milligrams. At 2 years, the 2Q8 arm received 14 injections, and there was 9.5 injections in the AQ12 and 8 injections in the AQ16 arms. And you can also look at the ability for patients to sort of maintain their randomized dosing interval, right? So patients who were started in the Q12 arm or the Q16 arm, what was the chances that they were still at that same dosing interval at the end of the trial? If you look at patients who started the Q16 arm, 84% of patients maintained Q16 week dosing through week 96. And if you look at kind of the pooled Q12 and Q16 arms, 89% of patients had at least a 12-week dosing interval through week 96. So again, it shows that the medication was relatively durable, allowing patients to maintain these extended intervals. And one final thing, again, I mentioned in year 2, patients were able to have their dosing interval extended. And so there's data from the last assigned dose, and patients at week 96, 27% of the pooled 8 milligram patients had a 24-week dosing interval, and 44% had 20 weeks or greater. So again, several patients, or sorry, a good chunk of patients were being dosed, almost every 6 months. From an anatomical standpoint, there was comparable improvement in central retinal thickness across all three arms at both week 48 and week 96. If you look at, I did mention there was a difference in the initial loading doses with 5 in the 2Q8 arm and 3 initial loading doses in the 8 milligram arms. And so you can kind of look at the drying power during the period of sort of monthly loading doses. And if you look at the 4-week period after the final initial loading dose, there was a greater reduction in CRT in the aflibercept 8 milligram arm as compared to the 2Q8 arm. And then if you look at 8 weeks after that last initial loading dose, the 2Q8 arm actually had a increase in the CRT relative to their last initial loading dose, while there was a slight increase from the 4-week point after the last initial loading dose in the aflibercept 8 milligram arms. It was still lower than the baseline from the last initial loading dose in the aflibercept 8 milligram arm. So again, relatively impressive drying power. And then finally, just safety. There was no new safety signals detected with aflibercept 8 milligrams. And this is a molecule that we're very familiar with. We've been using aflibercept 2 milligrams for 15 years almost. And if we look at the incidence of ocular and non-ocular adverse events, they were comparable amongst all three arms. Rates of IOI were relatively low, 1.5% or less in all three arms, and comparable. Specifically, there were no episodes of any retinal vasculitis, occlusive retinal vasculitis, or endophthalmitis. So again, a relatively good safety profile. So that's a relatively long summary, maybe the longer than we had intended, of the PHOTON study, but I think it's a nice background for the rest of our discussion.
So tell us, you looked at the baseline characteristics of eyes that could be extended 12 or 16 weeks. Isn't that right?
Yeah, so what we wanted to do with this sub-analysis was sort of look at which patients actually had to have their dosing interval shortened from these longer 12 or 16-week dosing intervals, and looking at baseline characteristics. Could we tell, which patients at the outset, might need a shorter dosing interval? I think that's important clinical information, as this drug rolls out. You don't want to treat someone with 3 monthly loading doses and automatically send them to 16 weeks and they do poorly. And so that's sort of what this analysis looked at, using the PHOTON data in a post hoc fashion. And so how the sub-analysis was carried out, we performed univariable and multivariable regression analyses to look at the various baseline demographic and ocular characteristics. We also performed an ROC analysis to try and identify sort of the optimal thresholds for characteristics that might lead to patients needing to shorten their dosing interval. And if you look at the sort of baseline characteristics for the two groups that we're looking at. So basically, there was one group who was able to maintain their randomized 12 or 16-week dosing interval, and there was a second group that had to shorten that dosing interval to 12 or 8 weeks, depending on where they started. And they're relatively comparable at baseline, those two groups. The one exception was that compared to patients who had were able to maintain their randomized dosing interval, patients who were had shortened dosing intervals had lower baseline best corrected visual acuity and greater baseline central retinal thickness. And so that also showed up in the univariable and multivariable analysis. If you actually look, there was a significant association with lower baseline best corrected visual acuity and greater baseline central retinal thickness, and the need to shorten the interval during at least the first 48 weeks of the study. And again, that's only obviously with aflibercept 8 milligram, as those were the patients who had those longer dosing intervals. And then the ROC analysis, again, trying to pinpoint what's sort of the cutoff that we should worry about. If we look at the pooled aflibercept 8 milligram data, we found that patients with a baseline best corrected visual acuity of less than or equal to 20/70, or a baseline central retinal thickness of greater than 475 microns, those patients were more likely to need to shorten their dosing interval. So those are the patients, your thicker patients with worse baseline vision. Those are patients probably that shouldn't be extended out so quickly. We also took those same two groups and sort of looked at the gain in visual acuity over the course of the study, did patients who maintained and did patients who had to shorten the dosing, did they still gain vision, or was there a difference there? And really, if you look at those two groups, from baseline to week 48, they both demonstrated robust visual acuity gain and robust improvement in central retinal thickness relative to their baseline. But if you look at absolute values, so absolute vision and absolute central retinal thickness, the group that had to shorten the dosing interval did have lower absolute values of best corrected visual acuity and greater absolute values of central retinal thickness at week 48. And we obviously hypothesized that was due to the worse values at baseline.
So what's the practical implication for the therapy of these patients? I mean, is there a visual acuity number that you can give us, or a CS central foveal thickness number that you can give us that points us in a certain direction? And then what should we do when we're going in that direction?
Yeah, so I mean, I guess I probably kind of lean on the ROC analysis for that question. I think those are patients. At least we found that patients with 20/70 or worse vision are ones who probably we're going to need to shorten from a 12 or 16-week dosing interval, and patients with central retinal thicknesses of greater than 475 microns similarly probably would need to shorten. And so what would we do with those patients? Those are patients I'd probably start out monthly and then go to 8 weeks instead of jumping right to 12 or 16 weeks. And then you kind of want to watch them for a while, right? Those are, there's no need to jump, all the way from 4 weeks to 12 or 16 weeks. And, it's going to be definitely an interesting experience for providers because, we're so used to going so slow. Now we have this data that says maybe we don't need to go as slow in terms of extension as we have in the past. I oftentimes, extend by a week or two at a time, but this data shows these patients do very well, and they're jumped out an extra 8 or even 12 weeks in one visit. And so I think what'll probably happen in sort of practical real world clinical practice is that these patients will be ended up stretched out more slowly, but those patients that have kind of better baseline characteristics, probably you might jump out 4 or even 6 weeks at a time, whereas those patients, like we just mentioned, with the worse vision and the thicker retinas at baseline, probably go from a month to 8 weeks and then kind of stretch out maybe a week at a time or so from there.
Well, there's plenty of evidence from the Vestrum database, among others, that more intensive therapy ends up with better vision, and that the story with eyes in diabetic macular edema is poor follow through.
Yeah, I mean, that's a challenge, right? Obviously we're at kind of a paradigm shift here with both aflibercept 8 milligram as well as faricimab, where these are medications that potentially can be dosed at these longer intervals. And it's a question: are we going to end up under treating these patients because we're telling them to come back at 12 weeks or 16 weeks, and then they miss their appointment and they don't come back for 8 weeks, and now they're at 24 weeks, and maybe that's too long. What I kind of see is maybe a future where we're treating these patients at more extended intervals, but maybe less than the absolute maximum extension. With our current medications, that maximum extension oftentimes is 6, 7, 8 weeks, and that's a challenge for patients. A lot of these diabetics are working age patients, and it's hard for them to repeatedly come in for these regular treatment visits. And so, what if we said you can come in every 8 or every 10 weeks? And that actually has a built-in sort of safety profile where even if they come in 2 or 4 weeks later, they're still going to be doing okay, with these, more powerful, more durable medications. And so, that maybe is a way to achieve outcomes that are more consistent with what we see in clinical trials, with that sort of real-world caveat that these patients are going to miss appointments, that are going to get sick, that they're going to have somebody come up at work and not make their appointment. And so, that's maybe kind of the sweet spot for these medications, as opposed to what we're doing now, which is like absolutely maximizing the ultimate extension because we're trying to, unload some of our patient volume, and these patients are trying to come in as infrequently as possible. But that, with these more durable medications, I think that's going to be, a lot easier to do.
Have you started to use 8 milligram aflibercept yet?
So we haven't. Obviously, as you know, it was just FDA approved at the beginning of this month. The beginning of, I guess, the middle of August now. So now we're into September. And obviously, I'm in a large private practice, and so we're always very cautious about making sure that payers have this medication on their formulary. So we were part of the Photon and Pulsar trial, so we have quite a bit of experience using aflibercept 8 milligram, but not in real clinical practice. Obviously, we want to make sure that our front office and the payers are up to snuff on making sure this medication is adequately reimbursed and not run into any issues in that regard.
So you were impressed with this being advantageous over 2 milligrams, though?
Absolutely. I think if you actually look at even preclinical data, certainly we see that there is a greater potency for sort of an anti-VEGF inhibitory effect. There was a rabbit model that showed, almost a 3.5-fold increase in inhibition of chronic vascular leakage, with a higher molar dose. And looking at these patients, we see definitely a greater drying power, and so it certainly appears that we're moving towards a more durable medication. So it kind of provides two things: more durability, but also greater drying power. But you can see it in the clinical trial. You can see it in your patients in the trial. But again, I think, and this is always the challenge with clinical trials, is that a lot of these dosing regimens are not exactly how we would dose our patients in the real world, right? I think that we're a little less tolerant of edema or changes in vision. And so I think, we will probably settle in somewhere in between, what we saw in the clinical trial and what we actually do in real life.
So we need to have you come back in 6 months or a year, and you can then tell us how 8 milligram aflibercept compares to faricimab.
Yeah, well, I think that's the hot question, Carmen. Really, and it's interesting if you look at the Tenaya and Lucerne trials, and you look at how Photon was designed, and they have two very different dosing intervals, right? So obviously in Tenaya and Lucerne, first time was dosed every 8 weeks, which was what they dosed aflibercept 2 milligram at, and then there was the PTI, which I know you're familiar with this, but the personal treatment sort of algorithm is like a jigsaw puzzle. It's very complicated and very difficult to discern. And so, with the Photon study, I think similarly, there may be a little more tolerant than we would normally be. And so it's very challenging to look at the clinical data and see the difference. And, fortunately, we never seem to get, or no one obviously is willing to, involve themselves in a head-to-head trial. But I think that'll be interesting to see. One thing that we do have some data on is if you look at protocol T, right? We look at the performance of Eylea compared to ranibizumab, in kind of more severe diabetics, there is a difference there, certainly at 1 year, maybe at 2, but certainly it seems like there's some signal there. And these molecules are still essentially employing a component of that, right? Faricimab still has a ranibizumab component, and Eylea 8 milligram obviously is just aflibercept at a higher dose. And so we'll see if there is a difference, at least for DME. And like I said, I'll be happy to come back on. Hopefully I'll have some real information for you at that point.
Eric, thanks a lot for joining us on Retina Synthesis. It was a great discussion.
Thanks, Carmen. Take care.